plantar fasciopathy. So as always, as Laura said, this is meant to be a bit of peer support. We've all got experience, and it's bringing those experiences together and then trying to obviously relate it to being in Nottinghamshire and our pathways. Please put it in the chat or just unmute yourselves. So I'm sure you've heard us a lot now, but my name's Desi and my colleague Laura. We're both first contact physios by trade, but also work for the Nottinghamshire Training Hub as AHP ambassadors. So today the aim is we're just obviously going to talk about what the current evidence and the literature about management and assessment of plantar heel pain, how it relates to primary care. And then I was fortunate to speak with one of the podiatrists that work for Nottinghamshire Healthcare, and he's given us the little hints and tips for the Nottinghamshire pathway. And then next month we've actually got Meet the Podiatrist, where he's going to come in and speak about the top pathologies he manages, and actually plantar heel pain doesn't come in, so that's why you've got us today. So all right, so I'm sure I've used different names already, but we're plantar fasciitis, plantar heel pain, plantar fasciopathy, all the same thing. But when we talk about plantar fasciopathy, it's because there's an absence of inflammation. So that's why these names float about. Most commonly, it will be plantar heel pain. So what is it? So it can be acute or chronic, and predominantly that inferior aspect of the heel. Most of the time it's an overuse, so most people won't say I did X and it came on. It will come on over time with that microtrauma, repetitive use. It's normally the medial aspect of the heel, and it's worse when you first get up in the morning, first putting weight on, gets better as you get moving, but when you do too much, that's when your symptoms flare up. Most of the time it is self-limiting and usually resolves kind of 6 to 18 months if there were no treatment involved. So other factors, we have to look at the extrinsic factors, that it can be around workplace, footwear, sporting activities, and we'll go through, sorry, losing my slides. And we'll go through a little bit more on the risk factors. So let's go back to anatomy. So the plantar fascia is a fibrous aponeurosis that starts at that medial aspect. Medial aspect of the calcaneus, and then goes into the deep ligaments of each of the metatarsals. It blends with that paratendon at the Achilles at the back. So that's why when we're going to talk about later that we're not just dealing with the sole of the foot, but its adjoining structures. Its main part is your biomechanics, so its aim is to aid that support of that foot. So when we do place our foot down, that we're not just getting flattened, and that it helps with that intrinsic foot musculature. So especially nowadays that we're devolved to require footwear, that's where we haven't probably got the same strength and almost dexterity at our feet. Now, the plantar fascia is also responsible for absorbing 110% of the body's weight, and it can go up to 250% when we're running and striking that floor. So it's just considering how much it needs to take for when we're doing our rehab and our interventions. So when biopsies are taken, they are seen to find micro tears in that matrix, and that's where there can be calcification, that degenerative changes when they do look under, as I said, in that biopsy. So most of the time there are those degenerative changes as opposed to a true inflammatory process, and that's where I said earlier we're looking more at fasciopathy as opposed to kind of the old fasciitis name. Even though some research has also said that it's also a chronic inflammatory process. So now the main people who get affected, females slightly more than males. Worst peaks are between 40 and 60 years old, but there's a high correlation with a high BMI. So basically anyone over a BMI of 25. It's got a high prevalence, 21% of athletes, especially runners, are on feet. And about 33% of patients will have symptoms bilaterally. Risk factors, I've talked about a couple already. Trauma is unlikely, but not saying it's completely impossible. Increased BMI is probably your main risk factor, looking at that lower limb posture. So is there leg length discrepancies, pes cavus, pes planus, reduce ankle dorsiflexion or that first great toe MTP extension. Looking at activity level, so loading, so how much you're on feet makes a big factor. So things that we'll ask in our assessments. So what do you do for a job? What do you do for activities? Have you just gone from a desk-based job to an on-feet job, even if it's just standing? Is it the 1st of January and everyone becomes a marathon runner having not done any on-feet training before? So it's having a look at that whole picture. Asking what normal footwear is for them. So have they changed trainers brand, or is it that we're changing seasons? So even when we go from nice sturdy winter shoes to flip-flops and sandals and Crocs, I'm not against Crocs, but it's just looking at that whole picture of where these kind of changes can happen. So that change in activity, we're looking at metabolic conditions as well. So people type 2 diabetics can be a little bit more at risk. If there's general weakness, or what I said about earlier, weakness to the foot intrinsic muscles as well as the calf, that can contribute to these kind of symptoms, that overload, but also the ability to tolerate that stimulus. But also looking higher up the chain. So is there a tightness or weakness, calf, hamstring, glute, going up, and having a look at what the demand is that the patient is asking of their lower limbs. Heel spurs, so we get quite a lot of patients that will ask about that. About 50% of people with plantar fasciopathy will also have a heel spur. However, this is not deemed the cause. It does not change the management, so if it's there, we do exactly the same thing. Therefore, x-rays are not indicated for heel spurs, and that's where even the podiatrist is saying that this is not something they'll consider. So it's just when patients bring it up, the management is exactly the same if it's there or not. It could be an incidental finding, but the management will remain exactly what we're going to go on about. I'll hand over to Laura.
Hi guys, so just talking a little bit now about the signs and symptoms. So it's very typical that somebody will report this heel pain, which can be stabbing or knife-like in character. It's very often at the kind of front medial side of the heel, but the symptoms can progress kind of along the sole of the foot, mostly in the central arch. It can also radiate to the lateral heel as well, so kind of the outside of the heel. To make a diagnosis of plantar fasciitis, it should improve with rest. So typically the patient should be almost pain-free if they're not standing on the foot and not moving the foot. You have this very typical report of pain first thing in the morning, when they first get out of bed or after having been sat for some time, but the pain should generally improve with a little bit of activity. So you tend to find this pattern where inactivity makes it much worse, activity makes it a little bit better, and then the symptoms can become worse again with too much or excessive activity. So yeah, typically people will complain of increased pain at the end of their day or at the end of a walk or the end of their work shift. Typically it's worse without any footwear on, so walking in bare feet on hard floors can often aggravate things for people, and NSAIDs can often make the pain a bit better. So if somebody reports that they have used topical NSAID or taken ibuprofen and their symptoms have improved, that can be quite indicative of it being a plantar fasciopathy. So in terms of assessing for it, there's this really good picture here of some footprints. So if you imagine a painted foot, obviously we've got the flat foot version and the supinated or high arch version of what those footprints would look like. And actually it's really important to look at somebody's foot as part of the assessment, but people both with a flat foot or a pronated foot, which would be the picture on the far right where most of the foot is in contact with the ground, or the picture on the far left where very little of the foot is in contact with the ground, which would be associated with a high arch. Both a high arch and a flat foot can be associated with a plantar fasciopathy. So you know, less likely, if you've got a nice neutral foot position, you're less likely to develop the problem. But either of those two extremes can be associated with the plantar fasciopathy. You tend to find that people have lots of tenderness on the medial corner of the heel. So kind of if you start at like the Achilles insertion at the back of the heel and track down over the bottom of the heel into the medial corner, you tend to find that that particular spot, which is where the plantar fascia starts, can be really, really tender. Movement of the ankle, the subtalar joint is normally pain-free, so they can normally move the foot up, down, in or out without any pain or without any movement restriction. So there's two tests which we know will normally provoke the pain. One is the dorsiflexion eversion test. So you would just passively bring the patient's foot up into a dorsiflex position or a position of a calf stretch, and then move the foot out into an everted position. So move the foot out towards the little toes, and that combination of movement can often bring the pain on in some the other test that can obviously often provoke or bring the pain on is the windlass test. So you would ask the patient to stand up. You can do this in sitting as well, but it's less effective. It's more effective in a standing position. And you would just try and passively lift up their big toe. And by passively lifting up the big toe, you put a big stretch through the plantar fascia. So if there is a plantar fasciopathy, that test is often painful, but also you would often see a lack of movement or a restriction to the movement of the big toe. So far, kind of if you're assessing somebody, deciding whether it's a plantar fasciitis or something else, we're thinking pain on the inside of the heel, an ankle which moves well, pain provocation with those two movements. Now, the other thing which is kind of important is that there's no sign of any neuropathic pain. So a plantar fasciopathy or a plantar heel pain shouldn't produce any pins and needles, any numbness, any kind of sharp shooting pain that we would associate with a nerve type pain. There is another condition which can present slightly with slightly similar symptoms, which we're going to discuss in just a second. But the main differentiating point between the two conditions is the presence of nerve type pain. So like I say, if somebody is reporting pins and needles, numbness, tingling, ulcer sensation, it's really very unlikely that it's going to be a plantar heel pain. And if you squeeze the heel and the heel is pain-free, that's a reassuring sign that it's not a compression fracture. It's always really important to rule out the fact that it could be a fracture of the heel, fracture of the calcaneus. So if you squeeze the calcaneus and there's no pain, it's kind of more evidence to support the fact that it could be a plantar fasciopathy. So I'm going to move to slide 14 now for anybody who's having issues with their slides. So hopefully this is going to work now. It's just a little video of the windlass test. This is being done in a seated position. I say there is evidence to suggest that it's slightly more effective in a standing position and probably kind of quicker to do in a clinic type environment. So let's hope that we can play this. We'll just see.
It's not a playable video. That's the picture, and then you get the link when you get the slides.
Okay.
Yeah.
Okay. So if you guys wanted to watch this video, then you can yeah, click on the link at a later date and watch that. So moving on to the next slide now, slide 15, we'll just talk for a minute about tarsal tunnel syndrome. So this is the condition that can present with similar symptoms, and it's a compression of the tibial nerve on the medial side of the ankle. So it can, because the nerve passes kind of around the ankle bone and down to the medial side of the heel, you can get pain in a very similar location. You also get pain with weight bearing, pain with compression, and you get pain on the dorsiflexion and eversion test. So the dorsiflexion and eversion test, which we talked about being a good kind of sensitive test to be able to pick up for plantar heel pain, can also provoke pain in this condition as well. So this is just kind of a good one to look out for. It's much more rare, it's much more unusual, but in somebody who is reporting those nerve type symptoms with pain in a similar location, it could be this, with kind of different treatment recommendations and options. So just a good one to look out for. So just to go over this again, the pain could be in tarsal tunnel syndrome, could be in a very similar location, but people would tend to have a positive Tinel sign over the tibial nerve. So if you tap on that tibial nerve just behind the malleolus, you could reproduce their symptoms, get tingling, pins and needles. You can get pain with the passive ankle dorsiflexion and eversion tests, like we've already discussed. But with tarsal tunnel syndrome, you can get wasting of the muscles in the foot, particularly your toe flexors. So having kind of weakness in those, the big toe and the toe flexors, that can cause some issues. The tarsal tunnel syndrome can cause some issues there. So yeah, looking out for that, and also people reporting loss of sensation on the sole of the foot. Those symptoms really wouldn't be symptoms of plantar fasciopathy. So moving on to other things that we need to consider before we decide on a diagnosis of plantar fasciopathy. We've had some suggestions already. So Baxter's nerve impingement, that's another kind of really rare nerve impingement, but definitely one to consider. Moving on to the next slide, these are kind of the main differentials. So looking out for a plantar fascia rupture, again, really highly unlikely, but more usual in someone who's perhaps used steroids in the past, or perhaps doing high level explosive sporting activities. Fat pad syndrome. So again, somebody who's perhaps had a lot of steroid injections in the past might be more at risk of having an atrophied fat pad. So plantar fibromatosis, so kind of like Dupuytren's of the hand, but presents in the foot. Again, very unusual to see, but you would get those kind of little nodules and a tightness in the sole of the foot, very similar to you would see in a Dupuytren's. Calcaneal stress fracture, tarsal tunnel syndrome, we've discussed both of those already. Tendinopathy, a couple of people have mentioned in the chat box, which is great, particularly of the flexor hallucis longus, can be really common in kind of dancers, sprinters, people who are doing lots of activities where they're kind of up on their toes. Achilles tendinopathy, normally if it's an Achilles tendinopathy, people will point to their Achilles, point to their heel, point to the tendon and tell you exactly where the location of the pain is. But it can kind of radiate round into the calcaneus and be, or it can happen at the same time. Do you know, you can get somebody that presents with an Achilles tendinopathy, who's also got plantar fasciopathy, because of that kind of fascial connection between the two structures. That's not unusual. And then kind of thinking lumbar spine, again, someone suggested that in the chat box, thank you. So an L4, an L5 or an S1 nerve root issue could cause pain in a similar location to plantar heel pain. See, normally you would expect somebody to report pain down the whole of their leg, with or without back pain. It wouldn't just be that kind of localized heel pain. And then if somebody's got bilateral plantar fascia or plantar heel pain, it can be associated with some autoimmune conditions, rheumatoid arthritis, or like psoriatic arthritis. So in somebody who's got a bilateral plantar heel pain, just thinking about doing that kind of whole body screen over the joints, looking for any signs of synovitis or signs of other associated autoimmune conditions like psoriasis, like inflammatory bowel disease, Crohn's or colitis. And in those patients, doing some bloods might be really helpful to screen. So thank you, Mohammed. In the chat box, he's just mentioned a couple of other potential diagnoses. So really, really rare, but in somebody with kind of heel pain that isn't going away. Always thinking about kind of screening medical history, and thinking about general health and whether it could be something metastatic or cancers there. So moving on now to investigations and treatments, really interested to know if you guys ever use imaging to help diagnosis of plantar fasciopathy, and we've just popped a little poll up. So if you're somebody who would diagnose it without any imaging, that's really interesting to know. And if you would choose to do an image, what would you choose to do? We'll just give you a second to submit your answers.
Right, we've got a clear first place of no imaging, followed by ultrasound. Oh, it's catching up, ultrasound.
So these results are brilliant, really reassuring, because they're very consistent with what the guidelines, local and national guidelines, suggest. So you don't need to image in order to diagnose a plantar heel pain or plantar fasciopathy. In fact, it's thought that X-rays are really of very little use at all, unless you're considering a stress fracture that you want to rule out. But otherwise, as Desi said, it's normal. 50% of patients who present with plantar heel pain will also have a heel spur. The heel spur won't be treated, it won't change the management. So knowing if it's there or not is of like very little, contributes very little really. Ultrasound should be considered.
Can I just jump in on X-ray? So
Yeah,
it's just to note the only time, and actually Mohammed brought it up, the only time that you might consider an X-ray is if you're looking at things like a sarcoma or a tumour, which obviously you should have a greater presentation or a medical presentation, like Laura said. But that's what podiatry have said. The only time where an X-ray would be a benefit is only, but that's where you should get that other history alongside. But only indication at the minute from them.
Yeah.
Sorry, back to you.
Great. Good point. Thank you. Yeah. So obviously, in cases where you're wanting to rule out a sinister pathology or a stress fracture, but otherwise, ultrasound is considered to be kind of first choice of treatment. Generally, you know, it's really affordable and easy to access in primary care. Ultrasound is really important if people are considering kind of seeking private treatments like shockwave therapy, which we're going to come on to in a minute. And it can also be helpful prior to steroid injections, although not essential. So ultimately, if somebody's had a plantar heel pain for more than a year, which hasn't responded in the way you would expect to our first line treatments, then that's probably where you would want to go in terms of imaging. MRI is rarely ever needed unless you're considering one of the other pathologies, and blood's equally rarely needed unless you're thinking that it could be an autoimmune condition and people are presenting with that bilateral pain, in which case looking at rheumatoid factor, anti-CCP and HLA-B27 is recommended.
So it's just on what podiatry have asked for. So actually in South Nottingham, they're not able to do any imaging. So that's where they said that if you've got someone that's almost tried the first line, which we're going to go over, and not responded, that's where you can send an image, and it's basically to help that triage service, just to confirm it definitely is a plantar fasciopathy. But we'll talk about it's when to refer to podiatry for plantar fasciopathy symptoms. In Bassett and Mid, they're able to order imaging, but again, exactly what everyone said in that chat, it's kind of ultrasound is mainly the main one, just to make sure there isn't another pathology, exactly like Mohammed has said as well, of not having a tear in the area. So I hope that. Yeah, is there anything else on you, from you, Laura?
No, not there. So kind of moving on to management of plantar fasciitis pain. Again, it would be really interesting to hear from you guys what you do, where you refer to. We're just going to pop another poll up. Just while Desi's organising the poll, Radar, I noticed that in the chat box you've asked when you would consider an MRI over an ultrasound. And I think somebody's replied here, which is great. Yeah, so the guidelines and the research around it really say that MRI isn't indicated if you're highly suspicious of plantar fascia pain. It would only be if it wasn't responding in the way you expected, wasn't responding to your first line treatments as you expected, was persistent, wasn't going, and you suspected something else, that you would then go for an MRI. But if you're pretty convinced that it's a plantar heel pain, but it just isn't getting better in the time frame that you would expect, and you think that you need more ongoing treatments, so thinking shockwaves, injections, surgery, then at that point ultrasound over MRI really.
So I'm not the quickest typer, but you can select multiple. Appreciate not everything is just one service. So obviously referring to FCP MSK, you might be that person anyway, so it's already with you. What's interesting about the podiatry versus physio secondary care, and that's probably what we can have a debate when we talk about first line treatment. Perfect. So thank you for everyone that has contributed to that. So first line treatment. So it's if you're having an FCP MSK in practice, or someone that's got experience in looking at the anatomy, biomechanical factors, when you assess that environmental factors, so having a look at occupation, what do they do as hobbies, activities, on feet time, footwear, that is all big part of this pathology of an overuse injury. So unlike, I played football and I got tackled, this is normally that micro trauma. So they won't be able to say on this day, but what's happened kind of 3 months prior to the symptoms starting. Yeah, like I said, that's why I made it multi-choice. It's normally a combined approach. It's not just a one treatment helps all. So making sure that we're addressing that pain, and we say inflammation, but appreciate the research is contradicting if there is an inflammatory process or not. We want to offload that tissue stress. So when we're talking about any kind of tendinopathy, we have to reduce what's the stimulus that's going in, because it clearly doesn't have the capacity to handle. We need to have a look at that muscle strength and flexibility to why is it coming on. Where possible, we said earlier that BMI is kind of the biggest risk factor. So advising on weight loss and other strategies, getting other services in place. So a bit like we had that MEC talk before, when do we need to get social prescribers, health and wellbeing coaches involved to be able to support these other pathologies? Consider foot orthotics. So this is where when we say off the shelf, that's where a referral to podiatry may be appropriate, but podiatry said they don't really do bespoke orthotics for this population because the wait time is too long to be able to get the assessment, get them made, get them back to that patient. And if anything, they use these medium density EVA. So they're like rubber. That's what they said is that texture. So it's not completely solid, but it's not like if you have an over the shelf and you can just fold it in half. So understand that there is a cost involved with these off the shelf, but that's sometimes your quicker way, and that's where you in practice might be able to advise some like other pathologies. I'll just show someone on Amazon, not that I'm endorsed by them, but these are ones that you could consider. Use things like heel cups. So again, it's that offload strategy. So that's sometimes that cheaper option as your first line kind of orthotic. You can sometimes advise on strapping, but obviously the big thing is about safety precautions. It might be sending YouTube videos. This is how you can do an offload strapping, especially some people that, you know, they can't get time off work because financial commitments, are self-employed. So what can we do as an offload strategy? The analogy I use a lot is a bit like a blister on your foot. You can take all the pain relief you want, but if you don't take the shoe off and leave it off, your blister's not going away. So same with these kind of plantar heel pains until we make a difference. So we can't just say go off your feet, but where can we make those offload strategies, be it strapping, activity modification, heel cups, or off the shelf orthotics. Having a look at that rehab side, so stretching, massage, mobility, but looking at that whole posterior chain. So some BMJ talked about it more about about hard splints or cast immobilization. So it might be like your Strasbourg socks, so wearing it at night. So it's just if it's tolerated. So if it's more that first weight bearing pain, that's more of the issue. That might be something that you consider for the patient. So be it the splint or things like the socks. Injections, so corticosteroid injections or anti-inflammatory drugs, that's where it's for that short-term pain relief when we can't move forward on another strategy because pain is so high, but we'll talk about that a little bit more. And then in primary care, make sure you do consider your amended duties. So if work is the main exacerbating factor, where can we say make that difference to offload? So is it, I'm going to go with postman because we see that a lot. Is it that Royal Mail are actually very good with their OC health of saying, you know, it might be that they do the first half of the day where they're on their feet, but the second half are in a more static or seated role. And that might be what we need to get the symptoms under control and then reload so that they can tolerate that. They have that capacity to tolerate the demand. Is it that they need to have a look at footwear and that, you know, their OC health needs to look into that? That's where we can be really powerful in keeping people in work, but just modifying that activity or stress. So rehab wise, so stretching, that's I appreciate I'm teaching some people to suck eggs. So non-weight bearing stretching exercise have been deemed more appropriate. So making sure we're going through calf, Achilles, but also through that plantar fascia. And most of the benefits will happen between 2 weeks and 4 months. But I won't go into this too much, but I appreciate I have a lot of physios in the room, and this is where there is a lot of resources out there. If I pass back to Laura, Shockwave.
So shockwave therapy is an option for chronic tendon pain. So we see it used a lot around the Achilles and the foot. In this area, unfortunately, it's only available to the South NOTH cohort via Connect. Podiatry don't have any access to shockwave therapy, and as far as we know, referring to orthopedics people wouldn't be able to access shockwave through that either, unless they belong to that kind of South NOTH cohort. For those of you who don't know very much about shockwave or haven't come across it before, the best way to describe it is like a very small pneumatic drill. So it's it's using sound waves to stimulate healing, and the sound waves are applied through this probe which vibrates quite intensely, so it can be quite an uncomfortable process to go through, but it's believed that the process can kind of kickstart and stimulate the healing process. It's really widely available through private clinics. So even if you live in a region where it's not available on the NHS, lots of people tend to ask about it and whether it's a recommended treatment. The research around shockwave is essentially that it is a safe treatment, that there's very, very few risks around it. But there is kind of uncertainty around how effective it is in comparative to other modalities of treatment, which is why it's not widely available on the NHS, and it's kind of a bit of a postcode lottery. So Emma's just dropped a note in the chat box. I know she's come from a background of working in private hospitals and had really, really good results with it. So yeah, it's definitely a safe treatment for people to pay for privately if they would like to. Just a few tips and advice around Shockwave. So it shouldn't be done within 12 weeks of having a steroid injection because of the risk of rupture to the plantar fascia. It's also recommended that people try to stop taking NSAIDs before starting Shockwave in order to have the best outcome. And people who've got tears in the plantar fascia or ruptured shouldn't have Shockwave therapy because it can make it worse. So the advice would be for somebody to have an ultrasound. So if you have got a patient who wants to access Shockwave therapy privately, it might be really helpful to order them an ultrasound so that they know that it is safe to go down that pathway. The main risks associated with it are just that it's uncomfortable. You can breathe in response to the treatment, and there is a small risk of increased pain and a small increased risk of rupture. And like all these treatments, it's better if it's used as part of a package of care rather than an isolated treatment. So I guess, most important thing is ultrasound before people have Shockwave treatment, and think about if steroid injections have been used to treat, just timeframes between having the steroid injection and then starting the Shockwave therapy. There is research to suggest that more than 5 treatment sessions won't be of any additional benefit. So somebody can have up to 5 treatment sessions, and it could be very helpful for these kind of chronic tendon conditions. But beyond 5 treatment sessions, if it's not worked, it's unlikely to work. So that's something else I always just tell people who are seeking treatment privately. Try not to buy kind of 10 Shockwave treatments as part of a package or something, because it is that kind of sweet spot of 4 or 5 treatments, which it has been shown to be most beneficial, and beyond that you're probably not going to get any more benefit from having any more treatment. Just 2 other treatment options that are also not NHS funded in this area, but available through kind of private physio clinics and private hospitals. One is the PRP injections, or the platelet-rich plasma injections. So again, there's really poor quality evidence to suggest that these injections are superior to having a steroid injection in terms of long-term pain relief, but the differences aren't significant enough for them to become kind of a mainstay treatment. So essentially what happens is a sample of the patient's own blood is collected, it's popped through a centrifuge, and platelets are re-injected in and around the tendon, with the hope that that's going to really try to enhance and create a healing response. It's used quite a lot, I think, in high level sport and with athletes, and again, widely available privately in this area. The other treatment, which is less widely available, I think, and used less often, but again is considered a safe option, is prolotherapy, which is where you are injected with a sugar-based solution. Again, this is thought to help with healing and repair. Research on it, again, there's weak research to show that it might be superior to having steroid injections or PRP injections, but the evidence isn't strong enough at this time. Again, though, no adverse reactions have been reported in any evidence in the research, so it's a safe thing for people to try privately if they would like to. Moving on from there, surgery.
So it's just a note on this one, podiatry don't do these, and they said they don't bring it up, but if a patient comes to them, they'll obviously discuss exactly what Laura has said, but this is not a service that is not commissioned, and then they wouldn't advocate for it unless a patient came forward wanting it, and they'd have to go private.
Yeah, so we've included that more just to be able to give patients some kind of information or reassurance if they've sought out their own options, because I think with these chronic conditions, people get fed up of the time frames for healing, and so it's quite common, I think, that people can start kind of researching and looking into other available treatments. So surgery for plantar heel pain is incredibly rare. The Podiatry surgeons within Nottinghamshire don't tend to do it because Desi can fill in a little bit more in a minute, but they find that the outcomes are very poor. But the research would suggest that 10% of cases which haven't responded to first-line treatment within 12 months might be appropriate for surgery. Did you want to add it?
Yeah, and this is where it's just basically there's 3 podiatry surgeons that work across Nottinghamshire in all our localities. But what they've said is they don't really do these surgeries. So other regions, they might have people that are a bit more pro-surgery, but that's why, and I'm going to go on the debate of physio versus podiatry later. It's what is appropriate, because what are they going to do differently? So if surgery is not really a mainstay, and obviously if there's another pathology, that's a different case. But otherwise, the majority are all managed with this first line care that we began with. So again, the NICE guidelines, and again, a very almost quick recap, is obviously that education to patient is probably that bigger aspect of telling people it's not a quick fix. It is going to take time, and it's usually like recovery is within a year. And that kind of self-care and making sure the weight loss, the modified activity, making sure you're wearing appropriate shoes. That's where those off-the-shelf orthotics or insoles and heel pads, so the heel cups, advising on that simple analgesics and anti-inflammatories, but we're going to talk a little bit more on another day about anti-inflammatories and over-the-counter. And that's where that short-term pain relief. So it's having, like Laura said, a steroid injection. So it said if it's considered appropriate, ideally ultrasound guided, but it can be done blind, and that the research or NICE has said that if it's been beneficial but symptoms return, you could consider repeat in 6 weeks. Now most FCPs might be working a PGD, which would kind of rule us out. Speaking with podiatry, so that's where they can do these ultrasound guided injections, but they said even they wouldn't do it within 6 weeks. So we know that there is a risk of ruptures, which is low but still a risk. But they said the thing that they would see more, and the more significant side effect, is that fat pad atrophy. So even if someone's had it 40 years apart, they said that they've seen this atrophy happen, and that actually they wouldn't be advising on injections unless, you know, they might boot people if it gets to a point pain is that bad that they need an injection. We need that kind of additional treatment alongside. So it's not that, you know, with more joint injections where you can get that longer pain effect. This is purely similar to shoulders to get that window, but again, it's not the fix. So it's just something we need to consider. And again, brought up in the chat, you know, it's not going to be the instant win, because it will come back, just back to my blister. I can inject it all I want, but if I don't take the shoe off and don't change anything else, it's not going to have that impact. So I think I've just covered that all already. So, and yeah, and this is where, and I'm more than happy if people want to unmute, all right. So it's probably considering an earlier physio referral than podiatry. So it's just podiatry. They're not going to do anything different to what we might do in primary care. And it's considering who's the quicker person or the more easier access person. Appreciate areas are a little bit different, but if it is going to be more around education, exercise, modification, podiatry are going to do very similar to either what we do in primary care or what can happen in physio. So as I said at the beginning, podiatry are going to speak to us about their top pathologies they manage and what they do, and obviously they can do more for some other pathologies, whereas this, they're not going to do anything that extra. So it's just something to consider.
Desi, just to double check, do podiatry have access to ultrasound guided injections, or
Yep.
only landmark? They do.
No, they do everything. All the injections they'll do is ultrasound guided. So when they come and speak to us, obviously they'll talk more about injecting kind of in the forefoot, midfoot, but they said everything's ultrasound guided for any of their injectors.
I guess that might be the time when you did want to consider a podiatry referral, possibly somebody who's had a blind or a landmark guided injection already with poor results, somebody who concerns that have had previous injections and therefore, you know, their risk of rupture is higher. Perhaps those people are more suitable for a podiatry referral because of their access to ultrasound guided injections. But I think in the past I would have referred to podiatry in the hope that they would issue or produce a bespoke insole. But I think due to their service limitations, that's not really what's happening. And so if we can just direct people to off-the-shelf insoles, probably quicker for the patient, and then reducing the burden on the podiatry service as well.
And I think it's like referring to podiatry where they can make that, their gift of their addition, those skills that they've got. Whereas and I think this is the hard part, like the ideal of what the guidelines say versus what access and provision we have. So if bespoke insoles orthotics aren't going to be what they can do, then yeah. So it's just food for thought. So BMJ, and again, it's just some of these differ, some of them are very similar. Again, they said about more the rest, the activity modification. BMJ went more about cast immobilization or things like that Strasbourg sock. So things that people, if it's more the morning symptoms, the cast immobilization, if pain is so bad that we need to completely offload, but it's how do they get hold of that? So having a true immobilization, that's why podiatry may do that, but again, it's thinking if they've had injections in the past, that's where their concern is, that fat atrophy. And even the example they gave was that it was a 40-year difference, and that's when it where they had it. And yeah, so it's not a sustainable injection, not a sustainable long term, it's just the window. And then if symptoms are still persisting, that's where BMJ says kind of shockwave or surgical, but we know within our podiatry service in Nottinghamshire, those two aren't really going to be considered. So what does it mean in primary care? So back to where we work. So consider about your analgesia, using your FCP MSK services if you've got them for that early advice, education, reassurance. If there's a high BMI or looking at metabolic conditions, what other referrals might be needed. So your health and wellbeing coach, social prescribers, depending what you've got available. Consider that referral for ongoing physiopodiatry, but have a consider of what we talked about today, of which might be the better service to go to, and manage what the service can offer. So again, that's where we know podiatry, the experts with feet, but just thinking today, what are they going to offer more than we can offer in primary care for this pathology? Consider your steroid injection, but only for that short-term pain. But obviously think about the warnings. They're a lot more significant probably in feet compared to other joints. And make sure that the rest of the package is in place. So like Laura said, like Shockwave, it's not that alone, it's that alongside everything else. Consider, especially in primary care, that you've ruled out your differentials, and making sure if you do bloods and radiography as needed. It's not normally indicated, but if things aren't getting better and they're doing the basics, have you ruled out all pathologies? It could be. And then refer to secondary care. The secondary care, if it's been going on, it says more than a year, but podiatry said if it's more than 6 months and they're doing the basics, that's where they should be in that secondary care environment. But that's where podiatry can't refer to MSK services. So actually, you choosing might be that better one. So that information today, but make sure that those basics have been trialed.